Welcome, everyone. We're just getting started here. While we're coming in, please feel free to enter your name and where you're joining us from in the chat. We'll get started here in about 1 minute. Just let people start coming in. Awesome. Okay, well, let's get started. Hello and welcome to the webinar. I'm Amanda Mahoney. I'm the marketing manager at Rasmus, and I want to go over a few things before we get started. First, you'll be able to earn one free CEU if you're watching this live and complete a few requirements. We'll share 3 keywords throughout the webinar that you need to write down. After the webinar, I'll share an online form to complete, and you will type in the 3 keywords to confirm your participation. A recording will be sent to all of our registrants. However, only live participants are eligible to earn the CEU. Rasmus is a mission-driven platform built to support the people caring for children with autism. Our story begins with a father navigating early intervention for his son Rasmus, and that experience continues to shape everything we do today. We're focused on reducing the burden on care teams so clinicians and caregivers can focus on the child in front of them, not the paperwork. Our platform is designed specifically for the realities of behavioral health, making it easier to capture progress, document sessions, and deliver high-quality care at scale. And we partner closely with providers every step of the way, from implementation through ongoing support. Ultimately, our goal is to help improve the care for 1 million children with autism by empowering the people who support them every day. And with that, I'm excited to introduce our guest speaker, Dr. Jessica Slaton. Dr. Slaton has over 15 years of experience in applied behavior analysis and special education. She's the director of applied research at Nashoba Learning Group, a Rasmus customer, and has taught in several ABA graduate programs. Her work focuses on supporting autistic children with intellectual disabilities and severe problem behavior. She's also published in peer-reviewed journals and serves on the editorial board of the Journal of Applied Behavior Analysis. Dr. Slaton, I'll hand it over to you.
Great, thank you. All right, let me just share my screen here. Make sure I'm sharing my sound too. Okay. All right, sorry, get it started. Okay, we should be in presenter view now, so you should all be able to see that. And thanks everyone for being here. I'm excited to talk to you about multidisciplinary collaboration in school settings. First, I want to acknowledge a couple people who have helped contribute to this. So I'm going to share some data and some case studies from my setting, Nashoba Learning Group. So I want to acknowledge the students and staff there. I'd also like to thank Rasmus for inviting me to speak with you today. And some of the data that we're going to share was a collaboration with Regis College with some of their graduate students in ABA. So I want to acknowledge and thank them as well. As a little bit of background about what I'll be sharing, so I'm a BCBA and special education teacher, and I've worked in several different types of school settings in different capacities. So I've worked directly in public schools. I've also consulted to public schools as an outside BCBA. I've worked with residential schools when we're helping transition students there. And I've spent the majority of my time in a day school setting. So the case studies and data that I'm going to share are coming from that setting. So we're a Massachusetts Department of Education approved school placement for kids who are not able to attend their local public school. So the school sends their students to us, and that's usually for a variety of reasons having to do with safety, maybe with dangerous behavior that's happening, or just a lack of progress. And in that school environment, we have BCBAs, we have special education teachers, we have the one-on-one therapists who work directly with the kids all day. We have occupational therapists, physical therapists, speech language pathologists. We have vocational specialists, life skills instructors, school nurses, administrators. So there's this big kind of multidisciplinary team that we operate with. And I think being able to work in such a large multidisciplinary team like that is, at least to me, one of the highlights and biggest strengths of serving kids in a school setting. I feel like I've expanded my knowledge as a BCBA so much just by constantly getting to work alongside professionals from all of these different disciplines. And I think an approach like that helps us serve students better because as a school especially, schools get a pretty broad range of kids coming in with very different needs, different profiles, disabilities. I think that's another highlight and strength of working in a school setting. So in non-school settings, like maybe a private clinic or like a university hospital program or an outpatient program, you may be serving like a very specific age range there or a specific diagnosis that's covered by insurance or something like that. But schools, especially public schools, get everybody and anybody. And obviously there's a lot of broken things that need to be fixed about our public education system. But one of the beautiful things about public education is that schools are for everybody. So working in a school setting as BCBAs, we're more likely to maybe encounter a particular need or profile that you haven't dealt with before. Maybe a student with a diagnosis that you've never served before, or a family who's navigating a situation that you've never worked with before. And those are all really great opportunities to learn and collaborate with other professionals and become a better practitioner. I think another highlight is that instead of working within that insurance funded model, we're serving students through their IEPs and under all of the federal and state regulations that go with that. I know for all of us who work off of IEPs, I'm sure there have been times when drafting an IEP or making sure that you've complied with all of those requirements was, maybe the bane of your existence in some moments. But I think it provides a lot of freedoms that insurance-based funding doesn't necessarily have. And IDEA provides a lot of protections for our students that they wouldn't otherwise have. So I think that's another benefit. And then just one more I'd like to share is that in a school setting, you're more likely to be able to follow students for longer periods of time, through the years. Now, like obviously families move away or they change schools and BCBA may change jobs, but a lot of kids remain in the same district or the same school system for many, many years. And so for the staff who also remain there with them, it really is a unique privilege to get to watch them grow up right before your eyes and for them to have those enduring relationships with trusted teachers. I've been able to recently go to a couple of graduations for students that I met when they were 5 or 6 years old. And I think that is just such a lovely gift for me and for them. But the flip side of all of this is there's also a lot of challenges and potential barriers that come with working in a school setting. And here they are. It's kind of the exact same list. So some of these things that make working as a BCBA in a school setting so great and rewarding can also translate into some really specific barriers to collaboration with other professionals. So that's what I'm going to go through next. And we'll also talk about the specific parts of the BACB ethics code that I think are the most relevant here. So these are some of the potential barriers to effective collaboration, especially in a school. So I think the first is time. With such a big multidisciplinary team, it can be really hard to find the time for everyone who needs to be collaborating together to actually physically get together and be together. And working off of an IEP can have, like I said, great protections for our students, but there's also a lot of time pressure there. There can be a lot of goals and objectives to work through and a lot of competing priorities. I've, had a number of students where maybe I was consulting to them for for example, severe head-directed self-injury. So part of what we're doing was figuring out how to protect them and how to manage that. But we also had to work through how to do our state mandated testing that all of our students need to complete. And our students typically submit a portfolio, but there's really specific requirements of what can and can't go in that portfolio. So maybe we're managing the competing priorities of, okay, we're just trying to get through the day without this child potentially giving themselves a concussion. But we also have this very real obligation from the Department of Education to document their progress and understanding of division or something like that. I think there can also sometimes be overlap in roles. And so sometimes there's not clarity over exactly who is doing what or who's responsible for a certain objective. So, for example, as a BCBA, I'm often working on things related to functional communication training. That's a well-known behavior analytic intervention. But then communication obviously is also the scope of the speech language pathologist who's serving the student. And we may need to coordinate there, especially if it's a student who doesn't have an established communication mode yet, and we're just getting to know them. And then sometimes in that overlap of roles or kind of lack of clarity about who exactly is working on what, we can end up with either conflicting recommendations or different recommendations from different professionals on the team. And that can be really tricky and sometimes uncomfortable to navigate. And then I think a last potential barrier that I've seen come up more and more is there's also this a growing amount of misconception about what ABA is and what we do, as well as some very valid criticisms that families and clients have brought up. So it can be difficult if you're in an environment where the other specialists that you're trying to collaborate with may not know what ABA is, or they may believe that it's inherently harmful or something like that. I do feel very fortunate to work in a setting where that's not the case, but I have talked with a lot of BCBAs, particularly in public schools, who are running into problems like this with their colleagues. So, in terms of what sections of our ethics code are relevant here, I think there's a bunch. I'm going to focus just on two. The first is this very clear direct one about collaboration with our colleagues. So you'll notice that it specifically calls us to collaborate with colleagues from other professions and to address conflicts by compromising when possible and always prioritizing the best interest of the client. And the other one that I think is relevant here too is this one, 1.05, that relates to the scope of competence. So when we serve such a broad range of kids and profiles and disabilities and needs, that means we're often put in a position where we need to kind of constantly expand our scope of competence to serve the kids that we're getting. And collaborating with other BCBAs and with other professionals in a multidisciplinary team allows us to do that appropriately and safely. So I'm going to talk through some ways to address some of these barriers. Obviously, there are not perfect solutions for all of these, but I'll try to share some things that I've done and some potential resources that I think could be useful. In terms of the issue of just nobody having enough time to do this collaboration, I think there are some system-wide approaches that we can take and some individual student approaches. In terms of systems-wide approaches, one thing that I have found really helpful but difficult to do is carving out dedicated time for collaboration. So just making that commitment to saying, I'm going to find a way to arrange my schedule and caseload so that on some regular basis, I have this time open for other professionals who need to stop in and chat about a particular student or an issue that's coming up. And we've been able to do that by just setting aside for some of our staff one afternoon a week where myself and some of our other senior BCBAs keep that time open so that other BCBAs can kind of sign up to come talk with us, or if needed, OTs, PTs, SLPs could also come and chat with us. And it was really hard to find that time and carve it out and commit to it. But we were also finding in cases where a lot of collaboration really needs to happen, but it isn't happening, chances are your time is actually already going there and you just don't realize it. Because for that particular student or case, you're probably spending your time maybe putting out fires or dealing with the crises that keep coming up or dealing with these complaints where the root cause is this lack of collaboration and communication. And so sometimes the issue of not having enough time to put into this type of collaboration is almost kind of an illusion in that your time actually is already going to this problem. It's just going in there in a way that you're not controlling. And so it makes more sense to figure out a way to take that time that you're already spending putting out these fires and dealing with crises and try to use it proactively to a bit more collaboration. I think it also really helps to figure out some efficient information sharing and documentation systems. Um, we do actually use our HiRASMUS supervision feature for that because it allows us to look at notes across providers pretty easily, so that you don't have a system that relies on tracking people down and talking to them face to face to get notes or updates for them, or even, a digital system where things are like stored in a way that it's just really inefficient to figure out what other providers are doing and how they're working on their objectives. We've also set up all of our data collections so that all of the specialists, our OTs and PTs and SLPs, even our vocational specialists, can access all of that data on the platform, even though they're not the ones designing the data and delivering the instruction. We make sure that they can have access to it easily. And then sometimes for individual students, we make a point of trying to overlap our consults where, maybe I'm coming in to see a student, overlapping with like the last 20 minutes that the SLP is going to be with them so that we can get in that time together. In terms of addressing misconceptions or criticisms about ABA, this is just how I operate. I'll share what I do with you. I think one of the first tips that I would share is to the best that you can, just represent our profession well. I think there's a lot of unfortunate stereotypes sometimes about BCBAs that we've probably heard about either being too inflexible or not interested in collaborating or things like that. So at the very least, try not to add to someone's view of that stereotype. And I think it's important to be aware of some of those misconceptions and valid criticisms that are out there and prepared to discuss it if it comes up, especially if you're in a school where there's a lot of negative views about ABA. I think you should expect that you're probably going to be confronted with them at some point, whether that's fair or not. It probably will happen. And I think it doesn't help to be caught off guard or surprised or seem totally unaware about the fact that there are these controversial topics. That doesn't mean that you need to like spend all of your energy deep diving into every single misconception and criticism that's out there so you can like mount this major defense. But I think on the flip side, it also means don't just kind of ignore it and pretend that it isn't there, that you hope you're not going to get asked about it and that it doesn't exist. I think when talking directly with maybe parents or families or other providers, I think it's important to respond with compassion and sincerity if they're sharing a previous experience they had that wasn't a good experience with ABA or with a particular provider. And sometimes the things that people bring up are valid concerns. So I think it's important to be prepared to listen without being defensive because you can correct misinformation without being defensive. You can empathize with someone without being defensive, and you can also explain how you practice without being defensive. And if you're finding that these conversations are coming up and that you're not able to have them without being defensive, I think it's also important to examine where that defensiveness is coming from so you can figure out how to navigate it and engage with this person in good faith. Now, obviously, this assumes that the other person, whether it's a provider or parent or family member, is engaging with you in good faith. They're not, you know, yelling and being accusatory or, swearing at you or threatening or like any of the things that we sometimes see online when people get into conversations about ABA. Obviously, you should not put up with that type of behavior. I would end the conversation if that's how it was going. But as long as the other person is engaging with you in good faith and it's a member of your team that you need to be working with, it's important to find a way to hear them and validate the concern, without necessarily validating the misinformation or misconception. So, for example, sometimes I will get comments from people that say things like, "Well, I've heard that ABA is abuse," and it's not helpful to immediately launch into, "That's not correct. What are you talking about? That's not how I practice," and whatnot. It's more helpful to be able to say, you know, that sounds really concerning. I've heard people say that too. I was surprised to hear that. If I heard that, I would be really concerned about this therapy as well. Let me tell you how I work with my students and how I practice. Or sometimes we'll have families who say, we don't really want ABA for our student, or we don't necessarily believe in it. That's happened a few times over the years. Um, but they are here at an ABA school that they chose. And so in those conversations, I try to just start from a place of curiosity and say something like, okay, that's so helpful to let me know. I'm curious, what made you select this placement, or what are your concerns that you've run into, and just um, take the conversation from there. And then I think it's also helpful to determine what your shared values are. What is it that we both want for this student or for this situation? Because that will help you move forward from a place of identifying a common goal, and it'll help you prioritize what's important to them potentially so that you can find some easy early wins and some easy places to collaborate. And it lets you kind of move forward from an understanding of, even if we disagree about some, specific components or methods, we're starting from that point of wanting the same thing for the student. This is kind of the messages that I try to convey when I have these conversations that come up sometimes. Just basically, I hear you. Your goals are also my goals. Here's how I plan to proceed, and how are you feeling about that? And that lets you get to what you need to be discussing for the student without putting your energy into trying to convince something, or convince someone about particular information related to ABA. In terms of the potential barrier of this role overlap and being unclear exactly who is working on what objective and who's responsible for what. First, hopefully that's something that can be made clear by your school administration or policy. Sometimes it's clear because it may be about who wrote the IEP objective. The SLP is implementing the objectives that they wrote, and we're implementing the objectives that we wrote. But often it's a lot more complex than that because objectives may fall under multiple providers. Um, like I brought up that example of functional communication training. And that obviously is something that the SLP may be working on as well, because it's a communication goal. Or sometimes our functional communication training goals really are also about self-advocacy and social pragmatics. So that's another reason that other providers might be involved. Or maybe you're working on an activity schedule as a leisure skill objective, but the activities that the student is doing is all of their fine motor tasks that the OT is overseeing. So there can be a lot of overlap. And I think the part that gets most tricky is when there's differing recommendations or approaches or just general philosophies to navigate. So I'm going to share some strategies for having those conversations. This is one really useful framework that I have learned about through all the different SLPs in my life over the years. The triangle of evidence-based practice. And first of all, I think it's a helpful decision-making framework, even if there isn't a conflict going on or conflicting opinions happening. And this frames evidence-based practice as considering the best current available research, but also the values and goals of the student and their family, as well as your own clinical expertise and other providers' clinical expertise. And I think that's important because if you only look at what's in the published literature, you're likely to have a lot of gaps. So there may be a gap there if the information you're looking for just isn't in the research yet. There's a huge research to practice gap, so it's possible that it just isn't there. It also may be the fact that what you're looking for in the literature, there's a ton of different evidence for a lot of different interventions. For example, I'm going to go back to functional communication training because that's what I do a lot of. Let's say that you've done functional communication training. You're ready to start fading the reinforcement schedule and thinning it out. And maybe there's disagreement between you as the BCBA and the SLP about how that fading should go. So you go take a look at what's in the research. You're not going to find one perfect study that compares all the different options and tells you the quote best way to do this fading. You're going to find a million different things. You'll find studies about delay and denial tolerance as part of skill-based treatment. You'll find response restriction. You'll find multiple schedules, chain schedules, and so on. And all of the individual studies will show some effects. And you could look at meta-analyses or systematic reviews, which can be really helpful. But those types of reviews don't necessarily exist for every possible question. And when they do, usually what they do is describe the current state of the evidence and conclude that to answer a question like, which of these things is best, we need more research. So it can give you a lot of information that will help inform your decision, but it's not going to answer the question for you of, like, what should I, me personally, in this moment, do for this student in this exact situation? So that's where weighing information based on your clinical expertise and the expertise of others, as well as the values and goals of the student and their family, can come together to help guide a decision about how to move forward, along with considering the best current evidence that's in the literature. And that consideration of the best current evidence also applies to not just external research evidence, but internal evidence for your particular student. So, what evidence do I have, if any, that this intervention may or may not work for this particular child in this particular situation? And I think these are some helpful things to reflect on your own before you have a conversation with the rest of the team or with the other provider. The first question being, okay, could this proposed intervention that we're disagreeing about, could it cause harm? I think 99.9% of the time the answer is going to be no. If the answer is yes, you have a clear path forward. Do not do something that causes harm. But almost every single time the answer is going to be no, it's not potentially going to cause harm. It may just fall into a category of something that you've never heard of before, or something that you haven't done, something where you're not sure if it's effective or if there's a research base, or maybe even something where there is some evidence indicating that it's not effective, but it's also not harmful. Another important question can be to ask yourself, can I describe this our intervention within a conceptually systematic framework? So even if it's an intervention that is not typically within your scope, if it's something that, as this other provider explains it to you, it's really easy to place it within the conceptual framework of applied behavior analysis. That can help you kind of sort out the best response. And then obviously, what does the research say about this intervention? And then what student-specific evidence do I have that this intervention may or may not be appropriate? And then when discussing it with the team or with the one provider where you're having this disagreement, I think it's important to start again from identifying shared values, because usually there are many, even if you've disagreed about this one particular course of action. And that's always a really helpful starting point, especially if the conversation is happening after there's already been some conflict or tension. So it's always good to start by affirming, okay, we all want the same things for the student. We all want them to be safe and happy and learning. There are no sides, there's only the student side, and we're all on the student side. And those are some kind of very broad shared values to start with. And it's a good idea too to get more specific, like we all want him to communicate more effectively, or we all want her to learn the job skills that she's identified as her personal goals. And then from that standpoint of shared values, you can start identifying the multiple possible courses of action. So there's maybe your thoughts on what needs to happen next and the other provider's thoughts on what they want to recommend. And collaborate on designing data collection to determine the efficacy of whatever it is that you put in place. And as BCBAs, I think we're uniquely qualified to do that, to say to the other provider, once we implement this, what would we expect to see that would let us know that it's working? And from there, you can get that data collection in place and then implement it and evaluate. And maybe the answer will be that this is effective for this particular student. And maybe the answer will be that it's not. But you're proceeding from an agreement on what we should be measuring in order to make that decision. So this is just one example of navigating that framework that I did with a team a while ago. So there was this question of, should we have the student wear a compression vest while he was doing some of his discrete trial programming to hopefully help with attending? And so we kind of went through this reflection. The first question being, could this intervention cause any harm? And it didn't seem likely. It was just a little Velcro vest that we would strap on him. And we had, I think, multiple OTs working with us, kind of overseeing how it's supposed to be used. What does the research say about this intervention? This was a while ago, and at the time, there was no research available. And I just checked, and I think currently there's still no demonstrations that wearing a vest like that specifically might improve attention during discrete trial tasks. It may do other things, but there wasn't any evidence for that in particular. And then we thought about, well, do we have any data about this specific student that would help us determine whether this could be effective? And there wasn't really any data that we had either for or against it suggesting that it would or wouldn't be effective. So we talked through, well, what are our shared values here, which for this particular student, we all wanted him to be acquiring his learning targets faster. We all agreed that we thought he could be learning faster. We all agreed that it would be really nice to have a simple and non-intrusive antecedent manipulation, like wearing a little vest. And then we just worked together to figure out the data collection to assess, is this helpful or not? And we identified that if what it's supposed to do is help him be more regulated and attend better, then that should translate to a higher percent accuracy in responding to his programs. So we put together an alternating treatment design and ran some sessions while he was wearing the vest and some sessions while he wasn't, so we could directly compare. And in that case, we saw there was no difference in his response accuracy with the vest versus without. So that really helped give us a lot of useful information. Now, does that mean that the student should never again wear a compression vest and it's forbidden or something like that? No. It just meant that we had the information to not rely on it as an intervention to improve the accuracy of his responding and improve attention. And that we should instead be exploring other data-based ways to improve his rate of acquisition, since that was the goal. But there could be other reasons he might still wear it. I think this particular student actually just really liked it. He liked it and he wanted to wear it and he enjoyed it. And so sometimes he still wore it because he asked to and he chose to. And we made sure that we followed the OT's guidance about how long should he be wearing it or should he have it on versus off. Or maybe it does have some effect on a different measure that we could choose to then evaluate systematically. So that was one, I think, simple example of how we applied that framework. We also applied this recently with some aided language modeling for some of our students who use speech generating devices. So aided language modeling is where the teacher or therapist is modeling language on the student's device as they're speaking with them. And in this case, it wasn't necessarily a conflicting recommendation. It was something that the SLP had shown us to do and that aligned with the family's goals and values. And we were interested in doing it. We just wanted more information. Because as we started looking at some of the studies, we found a lot of evidence for it, but we were seeing there's not as many examples where they did it as a standalone intervention without any prompting or reinforcement, just the modeling. And there weren't as many examples of kids just with an autism diagnosis who were using speech generating devices. So we thought, well, this is a great opportunity to gather more internal evidence about how this works for our specific students. So we worked together with the student's SLP. The BCBA selected appropriate functional activities for each child that we were going to look at. The SLP selected the vocabulary targets for each activity that we would teach during the activity. So, for example, I think one of them was playing the game Pop-Up Pirate with, there's like little pirates and like a sword that you put in a barrel. So the vocabulary words that we were working on during the activity were things like pirate and sword, things like that. We had the SLP review the procedure with us to confirm that we had understood it correctly, we were implementing it correctly, the way that it should be. And then the BCBA helped oversee this really nice multiple baseline designed to evaluate our students' vocabulary acquisition across these different activities as we were modeling the words. So here is what that data looks like. This project was done by some of my graduate students at Regis for their thesis. So it was a really nice, it was a nice project for them to be able to collaborate together with the SLP and kind of gather this internal evidence. So what you're looking at here are graphs for two different students. We have Michael on the left and Evan on the right. Across the x-axis are the sessions. And then the y-axis shows the percent correct responding to tacting items on their speech generating device. So during baseline, the teachers engaged in these different activities with them. So all of the materials and the vocabulary was there, but they weren't modeling how to label it on the device. And then during the aided language modeling, they would do the activity with the student and model the target vocabulary word. So in this first example, it says the rubber egg science experiment. He was doing a little science experiment where I think he put an egg in vinegar and it turned rubbery. And so they would do the experiment together and the teacher would model the target vocab like eggshell, yolk, things like that. And then before every session, they would do a probe where they showed the items and asked the student, what is this? And to see if the student could identify it on their device after just having seen it modeled. And you can see for these two students across these three different activities, it was very effective. We saw a pretty quick increase to 80 to 100% correct responding. And then we did some maintenance probes a week or two later after there hadn't been any more modeling. And for the most part, they still maintained a high level of responding. So for these two students, that was really helpful data to confirm. Okay, we were very systematic about teaching them a set of vocabulary words that we chose together with their SLP. And this is actually a really effective intervention for them personally. For our other two students, we saw something really interesting. So for this student, Chris, you can see for the first two activities, the modeling was very effective very quickly. He was able to start labeling those words on his device after a handful of sessions, and he maintained them. But then for the third activity, you'll see that we didn't see that much of an increase in his accuracy. We added a couple different modifications. And ultimately, when we added a direct gesture prompt, then he was able to reach 100%, but it wasn't maintained. And then for my buddy Leo over here, we found that regardless of the manipulations we did with this modeling intervention, we just didn't see acquisition. We definitely saw an increase in his accuracy, but we changed how we were doing the probe. We added gesture prompts, we added a visual prompts, and then finally we added praise and error correction and everything that would go into an intervention. And across all three of the activities, we saw some increase, but he wasn't able to master them. So this was so helpful for us to understand. Again, this is an evidence-based intervention that's in the literature. It was highly effective for two of our students. It was effective in 2 out of 3 of the sets of words for one student, and then not effective for this student. So I think that's a nice example of that idea of gathering internal evidence as well when you're implementing something that there is some literature base for, but you want to know, does it work with my particular student? So before we move on to the next section, just to summarize about addressing these conflicting recommendations, it is okay to have different opinions for providers on the team to have different philosophies or even to experience conflict sometimes. And disagreeing about what to do for a student doesn't mean that you failed or they failed or that anyone did anything wrong. It's something that we can navigate, especially when we start from a foundation of shared values. Remember that triangle of evidence-based practice. Remember as well that the ethics code explicitly tells us that part of our role in resolving these conflicts is to compromise when possible, and that as BCBAs, we're really uniquely posed to design the type of measures and data collection that we would need to get to evaluate whether an intervention is effective. Okay, I have another code word here to share for you. That word is flower. So the next code word you're listening for is flower. The next thing I want to talk about is problem behavior in schools. That's something that as BCBAs we are asked to address quite frequently. So I want to talk through that. For the sake of time, I'm going to skip ahead a bit and talk about first, what is the BCBA's role and responsibility here? And the first is to establish safety. So to identify whatever environmental modifications or antecedent manipulations you can do to make sure that child is safe while you are putting together your FBA, while you are gathering data and putting together your intervention. And that question of when should I involve other disciplines in treating problem behavior? I think for me, the answer is always, almost always. For example, we routinely work with our school nurse to have them help come assess potential injuries. If we have students who are engaging in severe self-injury, they help us assess the safety of the environment that we've set up. They also help just give us information for students who are on some of these medications for problem behavior of what some of the side effects might be that we should be looking for, what are some of the medication changes that the family has shared with them. So kind of helping us manage that information so we know what types of things we might want to be collecting data on. We routinely bring in the students' SLP for functional communication training, especially to help us figure out what's the right modality we should be teaching this functional communication in. Should this be something that's on the student's device? Should they be saying it vocally? Should they be using a picture? And then we bring in OT and PT often when there is a relevant diagnosis that might impact how this problem behavior is happening, or especially if there is any suspected um, pain or mobility or equipment needs that might really impact the type of function-based intervention that we can set up and recommend. To do this type of collaboration, I think I mentioned we set up this, once a week time that we have carved out specifically to collaborate with other BCBAs and other providers on students who are experiencing severe problem behavior so that we can get together and talk about a specific student if needed, and we have that time carved out. I'll share two quick just case examples of how and why we brought in another professional to help us work through problem behavior. So for this student, he's diagnosed with ASD and he also has a seizure disorder. And we are seeing some problem behavior related to sitting at the desk, and specifically tipping his chair back and forth and front ways and sideways and all of these things that as we're designing an FBA that we might do, they looked to be related to escape and attention from the teacher. So seeing the teacher having to jump up and make sure the chair doesn't go all the way over, and he thinks it's hilarious. So looking at that, a really easy antecedent manipulation as we're figuring out these other components like teaching him to appropriately ask for a break and things like that. An easy antecedent manipulation would be to change his chair and his desk arrangement so that this behavior isn't happening for the time being. Except that, given the seizure activity, he has a really specific chair that was selected by his physical therapist, a really specific seating arrangement to help ensure safety in the case of a seizure event. So before we did any changes or made any recommendations, we asked the PT to come to the consult with us and talk with us about, okay, what type of seating arrangement could be safe for this student that would be an effective antecedent manipulation for some of this potentially escape maintained behavior we're seeing, but would also protect him given some of the other diagnoses that he was navigating. This is another quick case example of a student where we really needed to work with another specialist to help fully resolve some of the problem behavior that we were seeing. So for this student, he has multiple diagnoses, and we were seeing problem behavior occurring specifically in the parking lot in the form of kind of flopping to the ground and rolling sometimes near cars or under cars. It was very dangerous. So a lot of problem behavior transitioning around the building. And we did have a lot of success following a functional analysis that we did for him in a function-based intervention where we worked on functional communication and we worked on waiting and delaying reinforcers and following teacher instructions and all of that. But there was still this residual problem specifically around the parking lot and getting out of the school and to the bus. And then after I had stopped consulting with the team, they let me know later that it turned out there was a whole diagnosis that we weren't aware of. The student has a cortical visual impairment. And once they had that diagnosis, and they started working with a vision specialist, a lot of the issues that they were seeing with transitioning out to the bus in the parking lot were able to be resolved because the vision specialist was able to help the team understand what were some of the skill deficits that could be addressed or environmental modifications that would make transitions more successful for him. So getting that diagnosis didn't change the function of the behavior. I think the function was still that he wanted to escape this environment and go do something safe and preferred. But it helped understand the reason he wanted to escape this environment was because visually he wasn't able to process what he was seeing, and it was feeling, I think, overwhelming and scary to him, and he wanted to be out of that environment. So we were able to adjust the environment appropriately by working with this other specialist. I'm going to jump ahead to share our last case study, which was for a student. So this is a student, Owen, that we worked with, and he was 8 years old, also diagnosed with autism and Fragile X syndrome. And the issue that we were seeing is that he was engaging in this high rate aggression and property destruction, flopping and bolting, but also specifically disrobing. And sometimes those episodes would last potentially up to 45 minutes or longer, because we just weren't able to get him fully dressed again. And so we would have to close down the area of the hallway that he was in or the room that he was in, obviously just to protect his dignity and keep it appropriate for other students. So it was significantly disrupting his ability to participate in school. And also, at some point, we needed to get through all of the 3-year testing for his 3-year reeval. So his SLP needed to do formal testing with him, ideally, if she could. We had OT and PT testing that needed to be done. So we worked together with the team to first do a functional analysis in the school setting. I know it can be tricky sometimes as part of an FBA to include the full functional analysis, but there are models that are easy to do in a natural setting that kind of capture the naturally occurring antecedent events and the naturally occurring reinforcers, and that can be done quickly and safely by responding to earlier precursor behavior rather than waiting for potentially dangerous behavior to happen. So we did that with him. I'm going to show you a sample. This is from his functional analysis. So this video here, you'll see he's playing with his teacher in the gym. She's chasing him around, and then she's going to ask him to leave and transition and go back to class and sit down and do some work at his desk.
Session 5.
Here he comes.
So Becky, next time you get to him, get the... Oh, that dragon's gonna get you.
Here he comes. He's got you. Hey, check it out.
Begin.
We're gonna go. Head back to the classroom. There. Can you match these for me?
All right, I'd reinforce that as a flop.
Yeah.
All right, never mind. Do you want to hang out in your beanbag, or do you want to go back to the gym?
Sure.
Yeah, let's go back to the gym. Let's go back to that gym.
Go, go, go.
Woo woo.
Nice job, buddy.
So you can see there, he did initially leave and transition with her and get back to his desk. He even sat in his chair. And the second, though, that she presented materials that looked anything like a work task, he was out of the chair and flopped to the beanbag. And again, in a functional analysis, we're looking to specifically reinforce some of those responses to confirm that we see responding stop when those reinforcers are delivered and get to what the functional relation is there. So at that point, we stopped and reinforced because we knew that if we didn't, that chain would continue to aggression and potentially disrobing. So from that baseline of recognizing, okay, his problem behaviors start with this initial flop and that they're evoked by the chain of demands to leave these fun activities and come sit at the desk. We then worked with his SLP to put together a functional communication training plan. So we collaborated with the SLP to select what functional communication phrase we were going to teach him, and also the topography, because he was a student who communicated in a lot of different ways. So based on the SLP's advice, we started teaching the phrase play please, and we modeled that for him vocally, but we also always had a picture card available that he could touch so he could respond in either modality, and we showed him how to use both. Here's what that looked like. So this is the very first session where we're introducing this picture card to him. And for this session, each time he makes that appropriate request to play, please, we were honoring it and continuing to play.
I'm gonna get you.
So, Jen, whenever you want, you could do the first trial. Oh, did you want to play? Choking, play.
Hey, let's go back to the desk and do some work, okay? Okay, let's go.
Oh, did you think you want to play? Play. Good, there you go.
So that was how we started. And from there, we started thinning the reinforcement schedule so it wasn't reinforced every time. We started introducing waiting and denial and saying things like, no, we can't play this time. We can't play anymore. Playing is all done. And we taught a bunch of appropriate alternative responses that we chained together into this longer and longer chain of actually leaving that preferred activity, starting to walk to the classroom, walking all the way to the classroom, sitting at the desk, starting your work, maybe completing just 1 or 2 trials and then 3 and then 5 and so on until we had chained together, being able to leave a preferred activity and go sit down and complete an instructional session with his teacher. And we incorporated his SLP into this intervention and had her come do the sessions with us. And here he is doing his 3-year testing with his SLP in the chair.
You ready? Let's go my pictures again. Look, 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 look. Show me toe.
Good job.
Nice listening. Are you ready? Look, look, look. Show me dancing. Ready? Look, 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 look. Show me gift.
I am going to go ahead and skip some of the ending here to bring us to your final code word, which is pineapple. So make sure to take note of that. Your final code word is pineapple. And as a quick summary, multidisciplinary collaboration with other professionals helps us serve our students better. It helps us expand our scope of competence. And this type of collaboration is a skill that we can practice and get better at. And even though there may be a lot of barriers in school settings in particular, there are also a lot of strategies that you can start putting in place to mitigate those. And thanks very much. The last thing I'll share is this conference, the Profound Autism Summit, is coming up next month, and it's a great resource for supporting multidisciplinary collaboration. So if you are in the Boston area or you feel like traveling, I think it's a great resource. There'll be talks from BCBAs, but also OTs, PTs, SLPs, psychiatrists, parents, policymakers. So all those disciplines under one roof. I think that's a great resource. I've included my email address here if anyone has questions they want to reach out about, and I can share a copy of the slides as well.
All right. Thank you so much, Jessica. That was wonderful. I think we only had one question, and that was, did you ever work on making the teaching and learning fun at the table? See more analysis?
Oh, yes. I mean, it's hard to share all the info in a presentation like this But yes, one of the things that we like regularly address for students is especially if we're seeing students resistant to coming to sit down and work. Why is that? What is it that they're trying to avoid? Is the curriculum not appropriate to them? Is it not interesting enough? Is it not being taught the right way? Yeah, there's a lot of, I think, manipulations that can and should be done there for sure.
Wonderful. Just going to share my final slide here. Okay, well, that just brings us right at time. If anybody has any other questions, Jessica did drop her email in there. I will send out, you should just within the next minute or so receive an email with the form to complete your CEUs. It's just a real quick Google form, should only take you a couple of minutes. And also after that, within about the next 24 hours, I'll send out the recording, Jessica's slides, and any other resources that she's able to share with you all. Thanks, everybody. Just make sure that if you have any questions about CEUs or if you're having problems with the form, to reach out to help@hirasmus.com, and remember to follow us on our social media. Thank you again, Jessica, and everyone.
Thanks.
Bye.
Bye.